But I am Rosemary Calder, and I've been one of the two people from Jean Hales and Victoria University that have combined to moderate the sessions that have occurred during these last 2 days. And this session is called Next Steps to Progress. My colleague in moderating those sessions, Erin Bowen, is up here with me because we're going to do a Tweedledum Tweedledee dance to try and give you an impression of what has transpired in these two very full half days. We won't apologise that this will not cover everything you said that matters. This is our impression of what we've heard that we think is important that everyone hears, because you all went to half of it. Very few of you went to all of it. So we want to give you a summary, a sense of what transpired through the sessions during these 2 days. And we want to engage you in adding to that, and you will see there are easels around the room which we will bring into open space, and there are sticky note papers with, what do you call them? Sharpies to write on. And we want you to add what you think matters, emphasise what you think matters, tell us what we've missed, talk about who else could be involved, add your thoughts today while you're here and it's fresh in your mind. We will also, obviously, through Jean Hales, you will be asked to add your thoughts and to start to engage in the next steps to progress through a web page that will be set up. And David Lloyd will talk about that in a moment. I'm going to talk briefly about the plenary session, and I'm not going to do it justice at all. And it's the criticality in women's health of addressing the psychosocial context across the life course, and the importance of gender competence for all health professionals who intersect with women across the life course. These are big issues. We're not going to make these happen tomorrow. But if we don't start tomorrow, we'll never make them happen. The importance of the recognition of women as peers in their health choices and in their health care. Another one, started in many places, in many different ways, but if we don't make it a universal principle and unite to achieve it, it too will remain elusive. The central role of health professionals and their needs, their professional leadership, as well as our sector's support for them to inform, educate and support practitioners in their roles as partners in the health care of women. Those were our take-out messages from the plenary. You will have others. If you feel they're so important you need to add them, there will be a whiteboard for you to add them to. There will also, of course, be a much more comprehensive summary of these 2 days. Mental health, a workshop or a session that I moderated and about which I care a lot, so I've added a bit of myself in here, I guess. The strong messages out of that workshop were that mental health is a life course issue, and it requires prevention and intervention in the early years of life through to older age. Mental health is not a response to mental illness when it hits. Mental health is ensuring that all women have optimal mental health across the life course. And that again, if we don't start working hard on that tomorrow, we won't see it in our lifetimes. Biology matters. We know that. We're watching with fascination the extent to which precision medicine is starting to open up the space in which individuals can be helped differently to their peers with the same condition. Biology in women's health is going to be critical to an understanding of good health, as well as to an understanding of treatment of ill health. So we've got to be mindful of that and be working across disciplines to make sure we mine the best of it. Again, psychosocial and environment factors are equally important, particularly for specific groups of vulnerable women. And mental health and well-being is part of every other health priority issue and area for women, and is very strongly influenced by the environment, by culture and by resources. So it's bigger than health, it's beyond health, but it's critical to health. And now Erin will talk about maternal, sexual and reproductive health.
Okay, try and get through these fairly quickly, seeing as we're trying to cover all 6 of the slides. Again, the need to take big picture concerns and translate that into clinical practice, quality outcomes and guidelines. We know that we are doing a lot at sort of large systemic levels, but unless we translate that into implementation and clinical care, then we're not actually delivering the outcomes we need. The need for early education and ongoing education about sexual reproductive health, and recognition again that all women are peer partners with clinical teams in decision making around their own sexual and reproductive health. And I think a really good comment was made in relation to all women in reproductive health should be considered level 4 consumers. So when Leanne Wells had talked about the sort of level of engagement of consumers, that was a really important point, I think, that women need to be completely engaged and considered peers. The need to link up a range of sectors that are relevant to reproductive health and healthy ageing, and again, we're coming back to this life course approach, recognising that what we do for women for sexual health and reproductive health is not just within that sphere. We start earlier and we need to extend with other areas of care. And again, this was another area that we've summarised it and sort of taken it to the higher level, but using underutilised workforce. We're saying all through the symposium, and it came up at the forums, that we have a workforce that is struggling with capacity and training and support and the things that we are going to put onto them. There are elements of the healthcare workforce that could do more. One of those was primary healthcare nurses that was raised, and I'm sure there are others that we could identify. They were sort of the key things that came out of that for me. So healthy ageing was the second session that I did. I think pretty much on every slide we've written the need for a life course approach, which to me speaks volumes about our need to work together within the sector, across the sector, and recognising that all of the things that we do for health start early, or preconception health as well. I really liked the idea of behavioural activation, and this was something termed by Bryony in her presentation, that it's doing more than changing thinking and cognitive action, but working with people to activate their behaviour changes and quite quickly turning what is a forced change, or something they have to think about, into a habit and something that people continue on doing. Preventable deaths in ageing need the same attention as preventable deaths in road safety. So we learnt that more people die from falls than they do from road traffic accidents, yet we don't really focus on that the same way that we focus on road safety prevention in Australia, and we need to do more of that. Another really interesting thing that struck home with me was the point that 85-year-olds today, who we consider have potentially a lot of comorbidities and some preventable health conditions, were probably a lot active, or most likely more active as children than our current children are. So whilst we're looking ahead at how we help a healthy ageing population, we need to be mindful that what is happening with our children now is going to greatly impact them as they age, and this is something we need to address. The other big message for me was around the stigma and barriers affecting women, including older women, and how we need to change language, we need to change attitudes, we need to address ageism and sexism, we need to engage women in the workforce, and we need to look at also the legislative and regulatory things that we can do that are barriers for women and ageing. And I'll hand back to Rosemary.
And the health impacts of violence against women of course, are again a life course issue. It takes many forms. What came through loud and clear in our workshop, but which is also a loud and clear message from any gathering of people who are looking at the issue of violence against women and all its forms. It is present at all stages and ages of women's lives. It is omnipresent, the threat of it, the possibility of it. And it's coercive, it's abusive, it can be subtle as well as visible and physical. And we are still, after many years of working on this, uneducated about the forms that it takes and the impact that has on women's health. It particularly affects younger women, and now most particularly affects current younger women through the new media that has such a pervasive and subversive effect on women's confidence and women's sense of themselves. It affects the reproductive health of women and their rights to make choices for their own health. It leaves, as I said, intergenerational and lifetime impacts. And the take-out message from that group was all areas of the health system have to know, understand and respond appropriately to the many forms in which violence against women take effect. And we talked about mapping the intersections with health of the mythical woman from preconception through to ageing, and the risk factors that arise at each transition in that person's life cycle for exposure to violence as a next step that should be considered. Preventive health, the strong message is here. We need to think about preventing intergenerational transmission of health impacts and risks and see that as central to our focus on prevention. That clearly applies to specific groups of women, Indigenous women most particularly, but also to CALD and other groups of women in our community. There's been work done on how to research and develop interventions that address those specific health issues. They need to be lifted up, looked at and examined for what they teach us about larger scale strategies to intervene in intergenerational impacts of violence. And clearly in this space, and not just this space, prevention is multifactorial. It needs not just the health sector, which comes in usually late, other than in early life. It needs other public agency sectors, particularly local government, urban planning, environmental planning, justice, education. It needs them all to understand how vital their role is in preventing violence against women and their children. Yours.
Right. So chronic conditions was the last other session that we had, and obviously it's linked very strongly with preventive health. When we did the forum, it was one forum. It is one priority area in the strategy, but I think we ended up with two quite distinct approaches through the different sessions. Take-homes for me, non-communicable diseases have distinctly different characteristics and impacts for women and men, and the example that was given is that for heart disease, it's more deadly in diabetic women than diabetic men. So the way our bodies respond to things are quite different, and therefore the way we treat non-communicable diseases has to be quite different for men and for women. And understanding that, it's not just the social, environmental impacts, that it really does come down to a lot of this biology is really important. Life course approach was raised. And for chronic conditions, we need to think about the best time to intervene to get the best outcomes. And one of the examples was recognising that low birth weight babies has an impact on when a girl has a first period, which has an impact on early menopause, which then has an impact on risk of chronic conditions. So how we can address some of those intersecting points and not just go, well, this has already happened, we can't do anything. What can we address now, but then what can we also take back to some of those earlier points of intersection to address? Large data sets are critical to be able to get the information we need to understand prevalence and burden, and then to be able to create a response. And I think we're very fortunate that we have access to longitudinal data sets and people who are able to link some of those data sets and work with national data that we have, which is currently not linked, but how we can work to better link that data to build a really compelling story for what it is that we need to do to address chronic conditions. Again, data platforms at a national level are essential. We have some really good data and data platforms, but we need to get that national approach. We need states and territories and Commonwealth governments and other data sources all working together. This was probably one of my favourite quotes of the symposium, and I wrote quite a few down that hopefully we'll see throughout the report, but collaboration is key. The recognition that we are stronger together. The more we can do this work together, the more we can take the ideas of one, build it with another person, and take a bigger picture approach, diverse experiences and opinions, and build better responses. I think the better policy implementation and design we will do. And I'll click on to the next because I think that's you. Yep.
So what we've put together for you, and it is our impressions. So therefore, it's there for you to add, critique, talk about in your responses. The overarching issues and actions that we heard come out of the dialogue across the 2 days are that there are multiple health and relevant public policy strategies in place, some very new, some long established. They need to be mapped to identify how they connect to and could integrate within the implementation of the National Women's Health Strategy. If we work alone and take no regard or fail to find the connections with those other strategies, we will put ourselves at risk and we'll do ourselves a disservice. As Erin has just said, the message across all the sessions was that we need to develop, access and link data sets to drive our case for change and to influence now, right now, the planned integrated health survey that Minister Hunt has committed to. It is being designed now. People are being consulted now. We had a very strong message about that from one of our AIHW participants yesterday. We need to take action now to influence that. It was very clear from everything that workforce capacity and support must be built for all healthcare providers that are critical to women's health. That's a big task, but again, one that we share with many others, and the interconnections with other strategies will help us think about that. We have to think about what happens outside of health that impacts on health outcomes. We all talk about it, but we need to work out how we are going to work with what is a vast sector. How do we start? Where do we start first? What's the priority first step towards creating change that will be visible and will influence further change? We clearly, as I already have said, need to map services across the life course for women and identify the gaps that exist now as a way of drawing attention to the priorities established in the National Women's Health Strategy. We have to fix the gaps in order to build what we need. And we need, and I think this came through every session, we need to recognise and invest in the importance of access to place-based care and particularly to wraparound services for vulnerable women. So those were our quick summaries of overarching themes. We now want to get your thoughts. You happy for me to go ahead, or will you do?
Yeah, if you can tell them where everything is.
No, I'll just hand over.
Okay, we thought it would be a good opportunity, one, to capture more of the thoughts, as Rosemary said, that we want to hear from you on either the existing priority areas. So we've got 5 easels up the front that have got a snapshot of the 4 questions that were asked at each of the forums that were then summarised for each of the priority areas. We'll pull those out so that you can have a look at those. If there's anything you want to add to or think needs strengthening, or even ideas on what we can do next in some of those areas, they will all be lined up along the front. At the back, we've got 6 easels which cover off cover off each of those points. We would like your thoughts on what we could do in those areas. Are these the things that we should be doing to focus on with our working groups and things as we move forward? And then we're going to take about 15 minutes to do that. So again, we'll spread those out up the back. There are sticky notes on the table. There are some pens on the easels, or you can use your own pens on the sticky notes and stick them up on the different ones that we want. We will take all of that information back with us as part of our summary from here. Please feel free to also write on there other things that you think should be at that sort of overarching key level that we haven't captured. Yeah. No, look, I don't think it would be my place to talk about the stuff that the ministers announced. There was money that was announced for, and they weren't direct, it wasn't directly linked to the strategy itself. So we're not saying we've got buckets of money that we would be able to put into this, but what we do want to say, and this is again things that probably came out at the forums, we want to look at what are the things that we can do ourselves, what are the things that we think we would need to take to government, and what are the things that we can scope for collaborative work. So, and you know, the aim would be to take some things to government, but also to try and do some stuff without having to go down that path. But still good points to write on there, what we want to see. So, we might start now. We'll get all the easels out. Please grab some sticky notes or just write on the butcher's paper. We'll take about 15 minutes. Then we're going to come back for a short reflection question time if we've got it.